Female genital mutilation, FGM, is a harmful practice that has no health benefits. The types of FGM. There are 4 types of FGM. Type 1 is either cutting part of or all of the clitoris. Type 2 is cutting part of or all of the clitoris and the labia minora and/or majora. Type 3 is closing up of the vaginal entry and a small hole is left open for urine and menstrual blood to pass. The clitoris and/or the labia are sometimes removed before closing up the vaginal entry. A type 2 can result in a type 3 if the raw edges from type 2 are stitched, pressed, or healed together naturally. Type 4 includes a variety of procedures that damage the external genitalia. The division between the different types are not always clear. There can easily be a mix of genital findings. Immediate health risks from FGM include severe pain and shock, infections, excessive bleeding, and in worst case, death. The long-term consequences may include difficulty in passing urine and menstrual blood, painful intercourse, infertility, HIV, hepatitis, psychological consequences, and birth complications. When a girl is cut, it can leave permanent scars in the vulva area. These scars make the tissue less stretchy at birth and can cause obstetric complications such as prolonged second stage of labor, perineal tears, newborn asphyxia or death, postpartum hemorrhage. Management of a pregnant woman with FGM. The first time you examine the pregnant woman, whether it's during pregnancy or at birth, assess the physical barrier caused by FGM. If you before birth determine that it will be possible to examine cervical dilatation at birth, and urethra is not visible, you can wait until birth to open up by performing deinfibulation. If you already determined during pregnancy that it will not be possible to examine the vagina to access cervical dilatation during labor, you could perform deinfibulation immediately to allow time for healing for the birth later. Discuss the deinfibulation procedure and its health benefits with the pregnant woman, offering her an opportunity to ask questions. If appropriate, and if she consents, offer to invite her husband to discuss the procedure as well. Deinfibulation. The steps for preparing and performing a deinfibulation are: perform hand hygiene and wear examination gloves. Clean the vulva area with soap and clean water or antiseptic. Give local anesthesia. Put on sterile gloves. With the flat end of a forceps, lift the scar tissue from the underlying tissues. With a scissors or scalpel, incise in the midline to expose the urethral opening. If there is any scar tissue from the cut of the clitoris, do not incise beyond the urethra, as the scar tissue may cause hemorrhage. If the clitoris is intact, have the opening done just above the clitoris. Be careful not to damage the urethra or any remaining clitoris. If there's bleeding from the raw edges, you must suture each raw edge in each labia to secure hemostasis and prevent development of scar tissue. Suture with interrupted sutures around the edges of the labia majora, leaving the vulva area open. Give oral analgesics after deinfibulation. Labor with FGM. If the deinfibulation has not been performed before birth and you cannot visualize urethra, you will need to perform deinfibulation. If possible, examine the degree of cervical dilatation to assess the stage of labor. The ideal time to perform deinfibulation is in first stage of labor, because in second stage there may not be enough space to perform deinfibulation. If you have to perform deinfibulation in second stage of labor, make the incision when the fetus is crowning. Be careful not to cut the fetus by inserting 2 fingers in between the scissors and the presenting part. Some women may have scar tissue in the perineal area, which will not stretch during delivery, and it might be necessary to perform episiotomy. However, the main indication for episiotomy is tight perineum in prolonged second stage of labor, particularly if there are signs of fetal distress. It is always recommended that you perform the deinfibulation before an episiotomy. Episiotomy should be performed mediolateral 3 to 4 cm, 60-degree lateral. After birth, it is important that the vaginal opening and urethra are not closed again. Counsel the woman and her husband. Explain that she will experience a change in urination and menstruation. Recommend her to wash her genitals daily. When washing, she should gently separate the labia with her fingers to prevent the raw edges from closing back together. Wash with clean water, followed by gentle drying of the area. Explain the health risks of reclosing. Advise to wait for 6 weeks with intercourse to allow adequate time for the wound to heal. Advise to protect the newborn, if female, from undergoing FGM and the same complications the mother went through. As a healthcare worker, it is your responsibility that the pregnant woman and her husband both understand the health risks of FGM and the importance of deinfibulation.